Welcome. This is the New England Journal of Medicine. I'm Dr. Michael Bierer. This week, July 25th, 2024, we talk about treatments for metabolic dysfunction-associated steatohepatitis, blinatumomab in adults with ALL, and sotorasib for KRAS G12C-driven vascular malformations, a review article on HIV-associated tuberculosis, a case report of a woman with rapidly progressive dementia, and perspectives on the abandonment of people subjected to sexual and intimate partner violence, on multicancer early detection tests, and on coping in the setting of serious illness. A new clinical decisions discusses hepatologist consultation in low-risk metabolic dysfunction-associated steatotic liver disease. This feature about a patient with probable metabolic dysfunction-associated steatotic liver disease offers a case vignette accompanied by two essays, one supporting referral of the patient to a hepatologist and the other recommending no referral. Let us know what you think. Visit NEJM.org to vote. Tirzepatide for metabolic dysfunction-associated steatohepatitis with liver fibrosis, by Rohit Lomba from the University of California at San Diego, La Jolla, and co-authors. Metabolic dysfunction-associated steatohepatitis, MASH, formerly known as non-alcoholic steatohepatitis, NASH, is a progressive liver disease associated with liver-related complications and death. This Phase 2 trial evaluated the efficacy and safety of tirzepatide, an agonist of the glucose-dependent insulinotropic polypeptide and glucagon-like peptide 1 receptors, in 190 patients with MASH and moderate or severe fibrosis. Participants were randomly assigned to receive once-weekly subcutaneous tirzepatide at one of 3 doses or placebo for 52 weeks. With regards to the primary endpoint, the percentage of participants who met the criteria for resolution of MASH without worsening of fibrosis at 52 weeks was 10% in the placebo group, 44% in the 5 mg tirzepatide group, 56% in the 10 mg tirzepatide group, and 62% in the 15 mg tirzepatide group. With regards to a key secondary endpoint, the percentage of participants who had an improvement of at least one fibrosis stage without worsening of MASH was 30% in the placebo group, 55% in the 5 mg tirzepatide group, 51% in the 10 mg tirzepatide group, and 51% in the 15 mg tirzepatide group. The most common adverse events in the tirzepatide groups were gastrointestinal events, and most were mild or moderate in severity. In this Phase 2 trial, involving participants with MASH and moderate or severe fibrosis, treatment with tirzepatide for 52 weeks was more effective than placebo with respect to resolution of MASH without worsening of fibrosis. Larger and longer trials are needed to further assess the efficacy and safety of tirzepatide for the treatment of MASH. A Phase 2 randomized trial of survodutide in MASH and fibrosis by Aaron Sanyal from the Virginia Commonwealth University School of Medicine, Richmond, and co-authors. Dual agonism of glucagon receptor and glucagon-like peptide 1, GLP-1, receptor may be more effective than GLP-1 receptor agonism alone for treating MASH. This trial evaluated the efficacy and safety of survodutide, a dual agonist of glucagon receptor and GLP-1 receptor, in persons with MASH and liver fibrosis. 293 adults received once-weekly subcutaneous injections of survodutide at one of 3 doses or placebo for 48 weeks. The primary endpoint of improvement in MASH with no worsening of fibrosis occurred in 47% of the participants in the survodutide 2.4 mg group, 62% of those in the 4.8 mg group, and 43% of those in the 6 mg group, as compared with 14% of those in the placebo group. A secondary endpoint of a decrease in liver fat content by at least 30% occurred in 63% of the participants in the survodutide 2.4 milligram group, 67% of those in the 4.8 milligram group, 57% of those in the 6 milligram group, and 14% of those in the placebo group. Improvement in fibrosis by at least one stage occurred in 34%, 36%, 34%, and 22%, respectively. Adverse events that were more frequent with survodutide than with placebo included nausea, 66% versus 23%, diarrhea, 49% versus 23%, and vomiting, 41% versus 4%. Serious adverse events occurred in 8% with survodutide and 7% with placebo. Survodutide was superior to placebo with respect to improvement in MASH without worsening of fibrosis, warranting further investigation in Phase 3 trials. In an editorial, Fasiha Kanwal from Baylor College of Medicine, Houston, writes that there is an urgent need for safe and effective treatments for MASH. By showing the effectiveness of dual agonists in patients with MASH, the trials by Lomba, Sanyal, and respective co-authors represent a substantial step forward. Together, they also highlight the potential for pharmacologic treatments to lead to an improvement of at least 30% in histologic outcomes, including fibrosis, data that are encouraging for both patients and their clinicians alike. Despite their importance, both trials were small, which could explain the lack of a clear dose response. Their applicability to the wider population is also debatable. In the trial by Sanyal and co-authors, 20% of the participants in the active treatment groups discontinued treatment owing to an adverse event, and those who had minimal unacceptable side effects after receiving higher doses may represent a subgroup of the general population. The burden of chronic conditions is disproportionately felt within historically marginalized communities, and the fact that the trials included few members of minority groups, especially blacks, was discouraging. Both trials were of short duration. In addition, results of withdrawal trials of anti-obesity medications have consistently shown substantial weight regain with cessation of therapy. MASH is a chronic condition that will probably necessitate continued treatment to maintain and augment histologic gains, although questions remain regarding when to stop treatments and in whom they should be stopped. Long-term treatment could also be associated with substantial costs and barriers to access that may widen health inequalities unless safeguards are in place. The results of the two trials also left open questions about the effectiveness of the treatments in patients with cirrhosis. Overall, these data are encouraging. Clinicians providing care for patients with MASH will probably have an increasing number of options in their armamentarium. With a growing menu of effective treatments, harms and unacceptable side effects will be important considerations in making treatment decisions. Blinatumomab for MRD-negative acute lymphoblastic leukemia in adults by Mark Litzo from the Mayo Clinic, Rochester, Minnesota, and co-authors. Many older adults with B-cell precursor acute lymphoblastic leukemia, BCP-ALL, have a relapse despite having a measurable residual disease, MRD-negative, complete remission with combination chemotherapy. Blinatumomab is a bispecific T-cell engager molecule that is approved for the treatment of relapsed, refractory, and MRD-positive BCP-ALL. In this Phase 3 trial, 488 patients 30 to 70 years of age with BCR-ABL1 fusion-negative BCP-ALL who had MRD-negative remission after induction and intensification chemotherapy were randomly assigned to receive 4 cycles of blinatumomab in addition to 4 cycles of consolidation chemotherapy or to receive 4 cycles of consolidation chemotherapy alone. The Data and Safety Monitoring Committee reviewed the results from the third efficacy interim analysis and recommended that the data be reported. Complete remission, with or without full count recovery, was observed in 81% of the enrolled patients. Of the 224 patients with MRD negative status, 112 were assigned to each group. The characteristics of the patients were balanced between the groups. At a median follow-up of 43 months, an advantage was observed in the blinatumomab group compared with the chemotherapy-only group with regard to overall survival at 3 years, 85% versus 68%, and the 3-year relapse-free survival was 80% with blinatumomab and 64% with chemotherapy alone. A higher incidence of neuropsychiatric events was reported in the blinatumomab group than in the chemotherapy-only group. The addition of blinatumomab to consolidation chemotherapy in adult patients in MRD-negative remission from BCP-ALL significantly improved overall survival. Sotorasib for vascular malformations associated with KRAS G12C mutation, by Antoine Fresnon, from the Hôpital Femmes Mères Enfants Hospice Civil de Lyon, Bron, France, and co-authors. Arteriovenous malformations are debilitating conditions caused by either inherited or somatic genetic mutations. KRAS gain-of-function mutations are frequently observed in sporadic arteriovenous malformations. The mechanisms underlying the progression of such KRAS-driven malformations are still incompletely understood, and no treatments for the condition are approved. In this report, the investigators show the effectiveness of sotorasib, a specific KRAS G12C inhibitor, in reducing the volume of vascular malformations and improving survival in 2 mouse models carrying a mosaic KRAS G12C mutation. The investigators then administered sotorasib to 2 adult patients with severe KRAS G12C-related arteriovenous malformations. Both patients had rapid reductions in symptoms and the size of the arteriovenous malformation. Targeting KRAS G12C appeared to be a promising therapeutic approach for patients with KRAS G12C-related vascular malformations. HIV-associated tuberculosis. A review article by Graham Mentkes and Gary Martins from the University of Cape Town, South Africa. Untreated HIV infection markedly increases the risk of tuberculosis, which globally remains the most common cause of hospitalization and death among people with HIV infection in the era of antiretroviral therapy, ART. The relative risk of tuberculosis among people with HIV infection increases exponentially as CD4 T lymphocyte counts decline. The risk is increased by a factor of more than 25 when the CD4 T lymphocyte count is less than 200 per microliter as compared with a count of 1,000 per microliter. Almost half of inpatients with HIV-associated tuberculosis in countries with a high disease burden of HIV and tuberculosis have mycobacteremia, and features of sepsis are commonly present. Tuberculosis can be diagnosed rapidly with the use of molecular tests, such as the EXPERT MTB-RIF assay in sputum and a LAM assay in urine, which together detect more than 2/3 of cases in unselected inpatients with HIV infection. Empirical tuberculosis treatment based on clinical and radiographic features is often needed in cases of severe illness, pending the results of mycobacterial cultures. Initiation of ART in patients being treated for tuberculosis can cause the paradoxical tuberculosis-associated immune reconstitution inflammatory syndrome, manifested as new, recurrent, or worsening symptoms and signs of tuberculosis. The syndrome can be managed or prevented with glucocorticoids. Isoniazid therapy and newer regimens, including rifapentine and isoniazid, are similarly effective in preventing tuberculosis in people with HIV infection, but the shorter rifamycin-based regimens are associated with fewer hepatotoxic effects and are more likely to be completed than the isoniazid-based regimens. However, access to these regimens is limited. A 78-year-old woman with rapidly progressive dementia, a case record of the Massachusetts General Hospital by Eric Smith and co-authors. A 78-year-old woman with a history of breast and lung cancers was admitted to the hospital with confusion. 5 months earlier, the patient began to have a flat affect. The patient had a 3-year history of mild problems with memory, but more severe memory issues had developed along with the change in affect. 4 months before the current admission, the patient was admitted to another hospital after an acute episode of word-finding difficulty that had been witnessed by her daughter. MRI of the head had revealed hyperintensities in the anterior and medial temporal lobes. MRI of the head also showed several lobar microhemorrhages. Treatment with aspirin was started, and the patient was discharged home on hospital day 3. During the next 14 weeks, the patient needed progressively more assistance with activities of daily living, including multiple reminders to eat meals and help with bathing. Her episodes of confusion occurred mostly at night. The patient's daughter brought her to the emergency department of this hospital after these episodes began to increase in frequency. On evaluation, the patient was inattentive and tangential in conversation, with perseveration. On admission to the hospital, the patient was found to have bilateral epileptiform discharges on EEG. She was also found to have medial temporal lobe hyperintensities on T2-weighted FLAIR images from MRI, an elevated CSF protein level, and oligoclonal banding in the cerebrospinal fluid, findings consistent with cerebral inflammation. In addition, the patient had a 75-pack-year smoking history, a personal history of lung and breast cancers, a recent history of weight loss, and probable seizures. In this patient, limbic encephalitis was suspected, possibly paraneoplastic limbic encephalitis. Blood and CSF antibody testing for autoimmune paraneoplastic encephalopathy panels detected antineuronal nuclear antibody type 1, ANNA1, also known as anti-Hu autoantibody, which is classically associated with smoking and neuroendocrine small cell lung cancer. Rape, homicide, and abortion bans. The abandonment of people subjected to sexual and intimate partner violence. A perspective by Elizabeth Tobin Tyler from Brown University, Providence, Rhode Island, and Samuel Dickman from Planned Parenthood of Montana, Billings. 2 years after the U.S. Supreme Court overturned Roe v. Wade in Dobbs v. Jackson Women's Health Organization, some of the many underappreciated consequences for women's health involve violence and pregnancy. Violence against women continues to be largely ignored and normalized by policymakers and the public. The rate of violence against women in the United States is 56% higher than the average among Organization for Economic Cooperation and Development countries. An estimated 324,000 U.S. women experience intimate partner violence, IPV, during pregnancy each year. 1 in 4 women in the U.S. is raped during her lifetime, and 54% are sexually assaulted. Rates of IPV and sexual violence are even higher for transgender people. Firearms are used in 2/3 of IPV-related homicides against peripartum people. Most states with abortion bans don't require relinquishment of firearms by people who have been convicted of domestic violence, leaving abusers with the means to usurp women's reproductive autonomy and endanger their lives. To develop evidence-based solutions to the crisis of violence against women, researchers and policymakers need access to data that are comprehensive and accurate. But statistics on rape and IPV vary dramatically among data sources, which makes it difficult to assess the scope of the problem and implement effective interventions. These authors believe the definitions of rape used in surveys should be broadened and aligned. The authors also believe healthcare organizations, hospitals, and insurers shouldn't bill people receiving care for conditions related to sexual violence. Such patients are often faced with hundreds or thousands of dollars worth of medical bills. Access to Medicaid coverage is especially important for people who have experienced IPV or sexual violence, because Medicaid covers medical services with minimal or no cost sharing. unlike most private insurance plans. Yet some states haven't expanded Medicaid. Multicancer early detection tests, keeping a high bar for evidence of benefit. A perspective by Hilary Robbins from the World Health Organization, Lyon, France. Cancer screening is on the cusp of a paradigm shift. At least it might be. The past few years have seen a surge in the development of so-called multicancer early detection (MCED) tests, which are intended to screen for cancers of various types simultaneously. MCED tests measure blood-based biomarkers, including mutations, methylation, and fragmentation of cell-free DNA. Thus far, the published studies in the most advanced phase of research examining such tests have been large, non-randomized interventional trials. The new era promised by MCED tests is alluring. Instead of subjecting people to scans, scopes, and smears to search for individual types of cancer, an MCED blood test could be regularly repeated, perhaps once per year. In 2021 and 2022, the National Health Service NHS Gallery study in England enrolled more than 140,000 participants who were 50 to 77 years of age in a randomized controlled trial to assess the efficacy of an MCED test developed by Grail. This test isn't designed to replace standard screening, but to be conducted alongside it. The primary objective of the study is to demonstrate a statistically significant reduction in the incidence rate of stage 3 and 4 cancers diagnosed in the intervention versus control arm, and final results are expected in 2026. NHS England initially planned to roll out the test to 1 million people in 2024 on the basis of results from the first year of the trial, but recently decided not to proceed, citing that early results were not sufficiently compelling. The specific metrics considered have not been made public. This turn of events has bewildered some cancer screening experts. But when evaluating MCED tests, it will be important for health authorities to maintain a high bar for concluding that there is evidence of benefit. Furthermore, at nearly $1,000 per person for some MCED tests, the cost of currently marketed MCED tests could overwhelm health systems. Should I laugh at that? Coping in the setting of serious illness. A perspective by Danielle Chamas from the University of California, San Francisco. What's the difference between my dad and cancer? Asks the 40-year-old man with metastatic cancer. When Dr. Danielle Chamas was preparing to meet her new patient, this wasn't where she imagined they'd start. I don't know. What? Dr. Chamas cautiously follows the patient's lead. At least my dad didn't beat me. Dr. Chamas's mouth opens, but words evade her. Can she laugh? Should she? Amused to have caught Dr. Chamas off guard, the patient breaks into a fit of laughter. Just kidding, the patient assures Dr. Chamas. His energy is contagious. Well, Dr. D, I brought these for you. He casually passes Dr. Chamas a sheet of stickers that read, "It was metastasized when I got here." A chuckle escapes Dr. Chamas. She wonders about the role humor plays in his coping. Like any defense, it's clearly helping him keep himself together through an unthinkably difficult situation. But Dr. Chamas doesn't yet know what else it may be affecting. Is it keeping a distance between him and the painful truths he needs to integrate? Or is it, on the contrary, allowing him to be more in contact with painful truths while staying psychologically intact? Before allowing herself to lean too far into the humor, Dr. Chamas tries to assess what they're working with. It's not every day that I start appointments in laughter, Dr. Chamas says. Tell me about what's helped you to develop such an upbeat mindset in the midst of everything that's going on. Listen, Dr. D, the amount of disease I have in my body is not something that will get better. He shares this news with a directness that many physicians can only aspire to. At this point, I'm not looking for a rainbow at the end. I have to make the rainbow now. In one simple phrase, Dr. Chamas has her answer. Not only can she lean into the humor, but doing so will serve him. In our images in clinical medicine, a preterm baby boy was noted to have hepatomegaly on the first day of life. Radiographs of the baby's legs showed periostitis and alternating dense and radiolucent bands in the distal femur, a finding known as a celery stalk appearance. A rapid plasmin reagent titer was 1 to 128, and a fluorescent treponemal antibody absorption test was positive. PCR assays of cerebrospinal fluid and nasal secretions were positive for treponema pallidum. A diagnosis of congenital syphilis was made. In another image, a 29-year-old woman with a history of systemic lupus erythematosus presented to the dermatology clinic with a 2-week history of a rash on her nose and hands that had appeared one day after the weather had turned cold. A diagnosis of chilblain lupus erythematosus was made. In a third image, a 2-year-old boy presented with a 4-week history of painless hair loss and black dots on his scalp. On physical examination, numerous black dots within patches of alopecia were seen on the occipital scalp. Trichophyton tonsurans, a dermatophyte that does not fluoresce under a woods lamp, was identified on fungal culture. A diagnosis of black dot tinea capitis was made. This concludes our summary. Let us know what you think about our podcast. Any comments or suggestions may be sent to audio@nejm.org. Thank you for listening.